Welcome to RUMC Connections. Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by gastroenterologist Dr. Vahe Shanazarian. Welcome. Thank you for joining us.
Thank you for having me.
Through RUMC Connections, you will meet the doctors, nurses, and medical professionals that make our hospital thrive. We'll also provide useful information about your own health, explore the latest medical news, and hopefully get you answers to some of your own health-related questions. The Ambulatory Center and GI Endoscopy Suites at Richmond University Medical Center provide full-service ambulatory services for children and adults. Each year, thousands of procedures are performed by our experienced physicians, nurses, and technicians. Our 6 state-of-the-art procedure rooms contain the most up-to-date diagnostic and treatment equipment available, including sophisticated monitoring equipment for your safety. Today we'll be discussing the importance of a colonoscopy, one of the most widely recognized screening procedures in the U.S. As of now, colon cancer is the 3rd most diagnosed cancer in America. Yes, so the American Cancer Society recommends that people who are at average risk of colorectal cancer begin screening colonoscopies at age 45. Unfortunately, there is a fear associated with the procedure, and it leads many individuals to get screened years later, which can delay the process of spotting cancer that could have been detected early on.
Right.
So we want to find these cancerous polyps and tissues. If we don't find them soon enough, that reduces the effectiveness of treatment, right?
Yes, exactly.
Yes. So through the years, we've heard numerous misconceptions regarding the process of having a colonoscopy, and we are going to debunk some myths and what you can really expect from the procedure. So Dr. Shanazarian is one of the latest physicians to join RUMC's practice. He earned his master's in public health degree at California State University, Northridge, and his medical doctorate from Ross University School of Medicine. He then completed his internal medicine residency at New York Presbyterian Brooklyn Methodist Hospital. Dr. Shanazarian served as a chief administrative medical resident at New York Medical College Metropolitan and completed his gastroenterology fellowship at the Brooklyn Hospital Center, a clinical affiliate of the Mount Sinai School of Medicine. Dr. Shanazarian is board certified by the American Board of Internal Medicine in gastroenterology and internal medicine. He has numerous publications in renowned journals, as well as many presentations at the National Gastroenterology Conferences, which he regularly attends. He's been named Best Doctor by New York Magazine, so we're in good hands today. Dr. Shanazarian brings his tireless dedication, work ethic, and modern cutting-edge approaches to his practice. He employs an evidence-based methodology and includes his patients in the decision-making process in order to provide the best, safest, and most satisfactory outcomes as possible. So, as I mentioned before, colorectal cancer is one of the leading causes of cancer-related deaths among men and women combined.
Yes.
However, there are tests to detect colon cancer in its earliest stages. So, what are some of the risk factors for colon cancer?
So the typical risk factors that we see, the more common ones, are dietary, family history, which can kind of lead into genetics, and environmental.
Okay.
So dietary-wise, we always recommend a little bit less red meat, more fiber, less processed things, processed meats, deli meats, things like that. Smoking is a risk factor as well. Genetics-wise, family history plays a very big role. Some of these things end up being inherited, but there's also very specific genetic disease states that can also really increase your risk for colon cancer. Those things the patients typically know because their family members have had, multiple family members will have had colon cancer. They typically get tested for it. That radically changes their screening methods and times. Frequencies, I should say. Anyone in the family has any history of colon cancer, you just want to speak to your primary care about it and then eventually your gastroenterologist about it, definitely.
What tests can be done to detect and diagnose colon cancer? Could you please speak about, colonoscopies and who should have them?
Yes. So there's a number of tests and, they all come with their own specific recommendations by the society guidelines. They range anywhere from stool studies to imaging studies to the gold standard, which is colonoscopy. We typically reserve the imaging and stool studies for patients who just absolutely refuse colonoscopy because anything is better than nothing. They're not as good as detecting colon cancer or polyps in general, large or small, as a colonoscopy would. But again, something is better than nothing.
Of course.
We always recommend colonoscopy as the number one test to do. It is considered the gold standard for colon cancer screening. Who should have it? Basically everybody starting at the age of 45, whether you have symptoms or not. We want to do it prior to you having symptoms because at that point, it's something is brewing.
Yeah.
So whether it's a large polyp or a cancer already, we want to kind of get to that before it has a chance to turn into something serious and prevent it from happening. It's actually one of the few tests that can detect and essentially prevent/cure a cancer in medicine that we have these days. Certain people should have it before the age of 45. Again, that all depends on if you have one of these genetic polyposis syndromes or if someone in your family has had colon cancer, depending on what age and what degree relative they're considered. Those specific cases you should discuss with your gastroenterologist, but otherwise, general population-wise, 45 years old, definitely.
Okay.
Yes.
And if a colonoscopy comes back normal, so to say, how often would somebody then get a colonoscopy after that first one?
So society guidelines say 10 years. Typically in the field, as physicians, we recommend about 5 to 7.
Okay.
Just because one of the risk factors that I always talk to patients about is a 0 to 1% chance of your gastroenterologist missing a tiny polyp. So knowing that that's a potential possibility, we prefer a little bit closer.
Sooner.
Yeah, doing
case
it
that
a little bit
grows.
sooner. Exactly.
Okay.
Now, the odds of that happening incredibly low. That being said, there's also things that occur called interval lesions, where essentially it's not something that was missed, but it's just a far more aggressive polyp that turns into something before that 7 to 10 year window. So those are also kind of things that we've been seeing more and more of over the last 10 years or so, probably more, but since I've been practicing for that long, I've been seeing it around that, in that time frame. So we do recommend slightly shorter intervals for screening. For myself, 5 years. So
Okay.
that's what I recommend to my patients,
years.
and then it's up to them to decide.
And for people who may not know, can you describe what a polyp is exactly?
A polyp is essentially a abnormal tissue growth in the colon. There's totally benign polyps, which have essentially a 0% chance of turning into a colon cancer. And then depending on what type of tissue it is under the microscope that the pathologist will look at after we remove the polyp and report back to us, there can be more aggressive types, less aggressive types, types that already have a cancer inside of it, but the way that we took it out left a nice clean margin, so it didn't have a chance to turn into what we would consider a true cancer, as opposed to something that's contained but has already started the change. So there's varying different tissue types.
Are all polyps screened, like even if it's a tiny little one, or?
Anything we see, we take out.
Okay.
Because anything we see has a potential to turn into a colon
into
cancer,
something.
a percentage each year, essentially.
Absolutely. Okay, that makes sense. Now, can you walk us through what a patient can expect to go through when getting a colonoscopy from start to finish, and how long does the procedure typically last?
Sure. So you come to the office, we have our visit, we discuss everything.
Okay.
We decide what type of preparation you should have. And there's the classic one is still the gallon, unfortunately. It's a really
Endless
great
fluids.
salty tasty drink, about a gallon of it. There are lower volume preparations these days. So unfortunately, it depends on insurance coverage.
Yeah.
Some patients don't care and they just want to pay out of pocket. There is a pill prep as well.
Yeah.
Doesn't work as great from what I've seen in my practice, so I
Okay.
kind of change the way
Prefer
we
the
do
drink
it.
method.
But I've used it; it does work. So there is that as
Yeah.
well. That being said, we schedule you. We go over the procedure in detail. We go over the risks, the benefits, and the day prior to your procedure is the day of your preparation. So you'll be on a clear liquid diet the whole day. Let's say the procedure's on a Friday.
Yeah.
So Thursday morning, from the moment you wake up, clear liquids all day. At a certain time, you start drinking the preparation. Makes you go to the bathroom a lot.
Yeah.
By the end of it, You want to be cleaned out so that we can carefully examine the inside of the colon during the procedure. You can basically have as much clear liquids as you want before, during, and after the preparation until midnight. After midnight, nothing by mouth, not even water, till we do the preparation, the procedure the next day. You come to either the office or the hospital, depending on your medical history, risk factors, things like that. And at that point, we'll chat with you. We'll get the consent forms done. The anesthesiologist will speak with you. They're going to place an IV. You get a little bit of what's called conscious sedation almost. It's not general anesthesia, where you have a tube down your throat. You're essentially getting IV medication that's going to make you very comfortable, like you're sleeping at home, breathing on your own. Every patient tells me it's the best sleep they've ever had. I feel like that's the only reason they come back.
A nice little nap.
And I'm okay with that. Once you're asleep, on average, a colonoscopy takes about 15 to 20 minutes. Could take shorter. Could take longer depending on what we encounter and what we have to do. Once the medication is stopped, within a few minutes, you're awake. And then within 15, 20 minutes, you're like alert. We chat with you about what we saw or didn't see and what we should do in terms of follow-up. And then your ride takes you home because you cannot work or drive the day of the procedure because of the sedation that you get. And that's about it, honestly. You go back to normal.
So you get a great
as long as everything goes the way it should, which it does, you're totally back to normal that day.
Okay. Do you recommend a particular prep diet for the days leading up to a colonoscopy? Aside from the actual prep that people do, are there certain foods that they should avoid or maybe include in their diet?
Not particularly. Most patients, the prep is enough. No matter what they've had the day prior.
So that doesn't have too much of an influence.
If there's anyone who tends to be more constipated, has a harder time moving their bowels, I ask them maybe have a little bit less meat, a little bit less higher fiber, like salads and fruits and vegetables in the days leading up to it, because that stuff, while it's good for you, the fibers especially, it's harder to pass and digest. So for those patients, I'll either have them kind of alter their diet a little bit in that sense, or maybe even take a pill laxative a day or two prior to the prep to kind of just help things get started a little bit.
That makes sense. And with the rise in colon cancer cases, what are some lifestyle choices that can increase someone's risk of getting colon cancer?
So smoking, in terms of lifestyle choice.
Which people might not associate. They might think smoking and just lung cancer, but there is a very close affiliation, right, between the two.
Smoking is a risk factor for almost every single cancer that we know of, unfortunately. So smoking is one big thing you can cut out. And dietary-wise, less red meat, because red meat is tougher to digest. Less greasier meats in general. More lean proteins are better for the colon. Higher fiber is better for the colon. This kind of falls into the less red meat, but less processed meats, like the stuff that has nitrates in it, deli meats, hot dogs, things like that have stuff that's not found in an animal naturally. So those are kind of some choices you could make to help a little bit. Great. Now, as we've discussed, prevention is the golden ticket to optimum health, right? So what should somebody have their first colonoscopy and therefore based on whether or not you find polyps? So you're saying the 5 to 10 year range is kind of the gold standard if they're good to go. I would say so. 45, 5 to 10 years. Again, it's kind of depending on the proceduralist, but on average, we do try to recommend between 5 and 7. And then again, if you have any of those other genetic risk factors, speak to your gastroenterologist, and you might have to start a little bit sooner, and your intervals might be a little bit closer together.
Okay, so let's get into a little bit of myth debunking and try to reduce some of the fear that people may have that prevents them from getting the procedure. So myth number 1, the risk of colon perforation and bleeding outweigh the benefit.
So big false.
Yes.
That's definitely a myth. On average, the risks of bleeding, perforation, infection is between 0 to 1%. And closer to 0%. The benefits far outweigh. I mean, on average, our detection rate, depending on gender, they haven't really updated those, but it's between 15 to 20%. So we're detecting things at that rate that we're removing to prevent colon cancer from happening versus a closer to 0% risk of some type of complication occurring.
Okay.
Yeah.
And myth number 2, I don't need a colonoscopy if I don't have symptoms.
So this one is actually a big deal because we want to get to patients before they have symptoms. You will not have symptoms typically until it's too late, unfortunately. So why do we get symptoms? What are the symptoms, right?
Yeah.
Because patients tell me, I'm totally fine. Unintentional weight loss, rectal bleeding, change in bowel habits, change in stool shape and size. Those are the more common symptoms that we see with colon cancer.
Okay.
Any type of symptom patients know their body very well. So they know when something is different. When you realize that, that's the right time to at least start asking questions to go
Okay.
see someone if you haven't had a colonoscopy yet, because you might not have even hit 45 at that point.
Yeah.
You know, we unfortunately see 30-year-olds with colon cancer.
Wow.
So don't ignore it just because you're not 45 yet. But that being said, if you are 45, if you're 50, if you're 55, you haven't had that colonoscopy yet, don't wait until you absolutely need the test, because at that point, it's not a screening test. Now we're trying to diagnose something, and
Yeah.
you don't want to fall into that category.
Get to that level. Of course, that makes sense. Okay. Now, myth number 3, the prep is horrible.
That's semi-true. So horrible, I guess, is very subjective.
Yeah.
I have patients who come to me, they're like, that wasn't bad at all, And then I have patients who are just miserable. They get a migraine or something like that, and you feel awful.
Yeah.
Hydrate. I think the biggest key is to hydrate.
Yeah.
And I think another thing that a lot of people don't realize is that, you don't have to mix the prep with just water. You can mix it with something that's more
Gatorade,
palatable to you. Yeah, Gatorade, ginger ale, flavored seltzer. It does help.
Oh, okay.
At the end of the day, you're drinking something that tastes like Pedialyte without flavor.
Yeah.
Right? So it's that like heavy electrolyte solution. It's not the end of the world, I promise. It's
Just a lot of
one
drinking.
time every 5 years, hopefully, or
Yeah.
less. And it does serve a purpose.
Does.
It's not the best, but think about all of the other things you put yourself through to like look better or do something that you really wanted to do. You suffer through it.
Yeah.
And you get there. And this isn't even
Exactly.
suffering.
No.
So you get to the point, you do what you have to do, and then you get that wonderful sleep.
Yeah.
And so it's all worth it.
So it pays off. You get a beautiful nap in the end.
Exactly.
Okay. Another myth is that a colonoscopy is painful.
You should not feel a colonoscopy whatsoever.
Yeah.
You should be asleep.
Yep.
You should be comfortable. You should wake up, and you should feel great.
And you're allowed
That's the truth.
to eat again as normal after
Yes.
the procedure, right?
Yes, there's typically no restrictions unless we take out a very large growth or something like that, where we'll ask you to be on liquids for about 48 hours to make sure the risk of bleeding is as low as we can make it at
Yeah.
that point. But that's not common. Yeah.
Okay. Another myth is I'm not at risk for colon cancer.
Everyone is at risk for colon cancer, unfortunately. And again, we see it far more than we used to. I don't know if that's because of better detection methods. Colonoscopy has been around for a long time, but the equipment has gotten better too. So now we're looking at bright white, high definition scopes and screens.
Okay.
So that's helping detection rates. But I think, subjectively, we're just seeing it more and more, probably related to diet and environment and just changes.
Well, have you seen an uptick in cases since COVID when people, lived a much more sedentary life and might not have been as active and maybe eating a bit more?
I personally haven't in terms of seeing more cancers,
Okay.
but
Well, that's good.
I've at least seen more people trying to get screened and things like that, being a little bit more health conscious. So that's been nice. So we have been doing a lot of polyp removals and things like that, but
Yeah.
thankfully it doesn't seem, at least in our experience, that we've been seeing more cancers, particularly related to that reason.
How is the colon cancer rate on Staten Island?
It seems pretty even across the board.
Yeah.
I don't think we have numbers that are higher than the national average, thankfully.
Okay.
And we have good treatment for it here as well. So if, God forbid, you get diagnosed, there's good options to be treated for it on the island versus having to go elsewhere.
Okay.
Yeah.
That's good to know.
Yeah.
We're not doing too terribly. Okay, so another myth is I'm a woman and less likely to get colon cancer.
Slightly less likely.
Slightly less
Yes.
likely.
Significantly less likely? No.
No.
You should still stick to regular screenings, just like men, and just be vigilant.
Okay. Another myth is that colonoscopies are expensive.
So colonoscopy should be fully covered by your insurance, especially screenings. Everyone's insurance is different and everyone's deductible situation is different. So I can't speak to that 100%.
Yeah.
But we always get an authorization for it from the insurance company. So they will cover what they're supposed to cover.
Yeah.
Yeah.
Okay, great. And another myth is I can just do an at-home stool test.
So technically you can. Is it as good as a colonoscopy? No.
Yeah.
And that's scientifically proven.
What do
with
the at-home
research studies.
tests show when you
So
study them?
there's multiple different kinds. The older ones only show microscopic bleeding. So notoriously bad test to do.
Okay.
The newer basic one also checks for some material being shed off of a polyp, let's say.
Okay.
So it's a little bit better. It can kind of help find polyps. But the best at-home stool test to do is that Cologuard test. It checks multiple different things. It's better at finding polyps and cancers.
Okay.
Typically, it's not a great test in terms of finding something in a stage that's more amenable to being fixed as opposed to finding something a little bit later. Again, if you're not going to do a colonoscopy, absolutely not.
Yeah.
Do a Cologuard at least. Do
Okay.
something. And it's convenient to do at home. You know, they ship you the box, you do the test, and they come pick it up.
Okay.
So, you know, it's like a standard mailing type thing. It's relatively simple to use.
Yeah.
You can do it. It's just not the recommended test to do.
Yeah, I mean,
and
it's
not
not
the
gonna-
best result.
Of course.
Yeah.
Okay. Another myth is young adults can't get colon cancer, which clearly you
False.
said is very false.
Very, very, very false, unfortunately. Yeah.
Are you seeing more of an uptick in younger cases?
More than when I was even in training.
Wow.
Which is really unfortunate. And we're not certain why yet. It seems like it's going to end up being more of this environmental dietary type of a reason, but we're not sure yet.
I mean, maybe with all of the electronics and the youth might be a little bit more sedentary
Maybe.
than in the past, and maybe the prevalence of more processed foods in people's diets.
I think so. I mean, if you look at the dietary changes over the last 100 years in
Yeah.
America, it's seriously different.
Very.
And it doesn't look like it's going to get any better in the near future, unfortunately. So we all kind of have to try to at least make better decisions.
Yeah.
Not every single time, you know, but overall, if you can,
Incorporate
it'll
more
help.
fruits and vegetables and
Yes.
whole grains and whole foods
Absolutely.
and things, right?
Yeah.
Okay. So another myth is once I get a colonoscopy, I'll never need one again.
no, once you start,
Yeah.
that's it.
That's it. You're
There
on
is-
board.
You know, they do recommend kind of evaluating patients at the age of 75 to see if they will need it. After
Yeah.
that, we scope 90-year-olds.
Really?
Healthy. We think they're going to live another 10 years. You know,
Okay.
that's kind of the question.
Yeah.
Is what's a person's longevity? Are they going to unfortunately pass away of their heart disease or their uncontrolled diabetes, or will it be a polyp that will potentially grow into a cancer in 5 to 10 years? So that's kind of the decision that has to be made with the patient.
Okay.
But that typically starts at 75 and later.
Yeah.
Prior to that, it's a good idea to do regular screening.
Okay. Are there patients out there who might have other pre-existing comorbidities that might make them more at risk for colon cancer?
Yeah, I mean, like you mentioned, sedentary lifestyle, but that kind of goes into like metabolic syndrome, patients who just have poorly controlled disease in general.
Okay.
It's not like written into stone or anything like that. If you have poorly controlled diabetes, if you have heart disease, if you have this and that, it's typically not just genetic. So like you have those other environmental and dietary concerns that are leading into it. So that would be the same concerns leading into colon cancer risk as well.
Okay.
So kind of in that like peripheral sense.
Yeah, that makes sense. Okay. So what do you want to leave the audience with today knowing about colonoscopies? What's your number one kind of takeaway?
Don't be afraid.
Okay.
If you've never had one, you know, talk to people who have. Typically, you'll get a pretty decent response other
Yeah.
than the prep,
Okay.
which you will get through. Like, don't worry about it. The anesthesia, again, is not general anesthesia. Don't be afraid of the anesthesia. You're going to actually end up loving the anesthesia more than anything else.
Best part.
And try to come in prior to getting any symptoms. Try to stick to those screening guidelines because that's when it will be of most benefit to you as a patient.
Absolutely. And once, God forbid, it does progress to colon cancer, is that a more aggressive cancer? I mean, is it easier to treat if you catch it early on or?
If you catch it early on, it's great to treat.
Yeah.
Anything that hasn't spread is contained to that part of the colon. Typically, surgical removal is curative. And a lot of the times now we have such good chemo that even then you might get a round or two just to be extra cautious.
Yeah.
But once it starts that spreading process, that's when you start to get into 5-year survival percentages and things that you want to avoid.
Of
If
course,
you
of
can
course.
avoid and surgically cure something, that's the number one goal outside of preventing it in the first place.
Yeah. Okay, that makes sense. Well, I would like to thank you so much for joining us today and for all that you do to keep us safe and healthy.
Thank you. I appreciate it.
Of course. And that about does it for this episode of RUMC Connections. For more information about gastroenterology services or to schedule a consultation with Dr. Shanazarian, you can do so by calling 718-448-1122 or visit www.rumcsi.org. Thanks for joining us. I'm Meredith Gaskins.